Gallagher, President of the American-Scandinavian Foundation, and it's my great pleasure to welcome you to this special webinar produced by the ASF on Iceland's response to the coronavirus with Dr. Gudrun Aspelund, head physician at the Center for Health Security and Communicable Disease Control at the Directorate of Health in Iceland. Hello, Gudrun. Nice to see you.
You too, Ed.
Since March 16th, the headquarters of the ASF Scandinavia House and Nordic Center in America have been closed due to the coronavirus crisis. Each year, the ASF presents over 150 educational and cultural programs at Scandinavia House. The current crisis has caused us to turn to the internet and programs such as today's. Future programs will highlight other nations' responses to the virus and other dimensions of the current crisis. In addition, at all times, our website features a wide variety of past lectures, symposia, exhibition tours, and children's activities. I encourage you to visit and take advantage of these. It's a particular pleasure to be welcoming Dr. Gudrun Aspelund to be with us today. A native of Iceland, Gudrun finished her studies as a doctor in Iceland before coming to the USA, where she pursued a surgical residency at New Haven Yale Hospital. She then pursued a pediatric surgery fellowship at the Hospital for Sick Children in Toronto, and subsequently started her career as a pediatric surgeon in New York at Columbia University Medical Center's Morgan Stanley Children's Hospital. She also studied at the Mailman School of Public Health, where she received a master's degree in biostatistics. After 10 years as a pediatric surgeon at Columbia, she became chief of the section of pediatric surgery at Westchester Medical Center in Valhalla. And shortly after that, she returned to Iceland, where she took her current position. Again, Gudrun, it's great to have you with us. And we should start by saying that nations across the globe are dealing with the challenges of coronavirus. Iceland's first incident of the virus was on February 27th, and since then, I believe there have been nearly 1,800 cases and 10 fatalities. The response of Iceland to COVID-19 has been rather different than many other countries. I wonder if you could give us a little background on the first appearance of the virus in Iceland and the subsequent growth of the virus.
Yeah, it's my pleasure to be here with you today. Our first case was diagnosed on February 28th, and that was a traveler who was coming from North Italy from skiing. However, a month before, or January 27, we actually implemented what was called an uncertainty phase, which is the first of 3 civil protection emergency phases. And that was done because of the news of this new coronavirus and the disease it caused. At the time, they didn't have a name yet. We had this month to prepare, and there were various measures taken, various documents that were updated and written, instructions, including for airports, healthcare facilities, and other frontline people. And testing began at that time as well. So we had been testing for 1 month before the first case was diagnosed. Initially, all the cases were travelers coming from first Italy and then all over the Alps. And then those were, subsequently there were travelers, there were their families and co-workers mainly. On March 6th, though, we had our first domestic infection confirmed. And at that point, we entered a state of emergency.
Can you describe, you obviously had an early response, you said back in January. What are the various responses that you have used to control the spread of the virus since the first occurrence, and how have they evolved over those 3 months?
So yeah, in January, initially, right away, there were daily consultation meetings in what's called the National Crisis Coordination Center, which is the chief epidemiologist, the police, and the director of health. And they had been meeting daily and planning their responses based on a document that's called the Icelandic Pandemic and Influenza Preparedness Plan. And this had to be updated, but had been written several years ago. And the strategies that were then taken were suppression and containment and what's called mitigation. And mainly, I mean, apart from official advice to the public, to businesses, a lot of information sharing, the emphasis was on identifying cases. And we were very aggressive with testing and then isolating the cases, as well as contact tracing and quarantining those that were thought to be exposed. So those were the measures taken pretty early on. And another important thing was protection of vulnerable populations. There were special instructions published for the elderly and other vulnerable groups, how they could protect themselves especially. And they were also encouraged to stay at home if possible after we had our documented infection inside the country. And at that time, nursing homes, long-term care facilities and hospitals also implemented a visitation ban for their residents and patients. So those were kind of the initial steps. And then in middle of March, other restrictions were implemented. There was never a lockdown, but there were restrictions on social gatherings, including physical distancing between people, and then restrictions on various businesses, as well as partial school closures. And initially, the restrictions were that maximum 100 people could gather. They had to be 6 feet apart from other regulations. And then a couple of weeks later, this was made stricter with only 20 people, and all businesses that had any like physical proximity, like hair salons, beauty salons, those kind of things were closed. Sporting facilities. However, the primary schools were kept open, and daycare centers, and grocery stores also had more flexibility in that they could allow more people to enter than, for example, other stores. So there was a bit of flexibility in there. And then all elective surgeries were also banned, as well as any non-urgent medical care, basically. So those were, that was all that happened in March. But before that, people had been made to go into quarantine. All Icelandic people or Icelanders, I include everybody who lives in Iceland under that heading. They had to quarantine if they were coming from certain areas. And those areas initially were certain countries and territories, and that was gradually expanded until March 19, that became the whole world.
Reykjavik is quite a center of travel, with many connections from other places being made there. Were there any restrictions put on the number of flights that could come in to the airport, or connections that could be made there?
No, so we did not do that initially. The borders were open. There were no entry screening of passengers either coming here or coming through here. The quarantine I mentioned for residents did not apply for tourists, so they were still coming at that time. However, the European Union and the so-called Schengen territory, they implemented travel restrictions that we agreed to participate in, and that was on March 20th. So then only people from that area can come here. So that is basically the Schengen area, European Union, UK, but other nationalities cannot enter the country.
Mm-hmm. Okay.
And that is in effect still until May 15th.
May 15 is and does that also apply to all the other lockdown restrictions? May 15th is the end date?
No, actually not. So tomorrow we will change the quarantine rules, so they will include tourists. So those people that are really not coming, but if they would, then they would have to go into 2 weeks of quarantine. So there won't be this distinction between residents and tourists anymore, and that is supposed to be until May 15th. The restriction on social gatherings and businesses is until May 3rd. And those, how we are going to back away from that has already been published, but it won't take effect until May 4th. So instead of 20 people, there will now be 50 people that can gather. Various businesses will be allowed to open. For example, those that I mentioned with that involve like close physical proximity, like hair salons, beauty salons, and some of those, as well as regular medical care, and dentists can start working again. And there will be a relaxation also in the schools. So already the primary schools were open, but they had some restrictions that now will be lifted. And secondary schools and universities will be allowed to open again. And there will also be some relaxation about sports, especially for children, less so for adults.
So you are seeing a decrease in the number of cases to date?
Yes, certainly. We had about the end of March, late March, we reached the peak. And I mean, we are a small country, but then we had about 100 new cases a day. Subsequently, they started going down. These were new infections, so the cases, linger on as infections. But then in early April, we started going down, and we have been going down since. And almost for 2 weeks now, we've had very few cases, under 10 a day, and the last several days around maybe 5 a day.
And of those cases that have taken place, roughly 1,800 total, how many have been hospitalized?
So the total number that, let's see, that was, I don't have that here. Right now, I know 15 people in the hospital.
Mm-hmm.
And there were, we did lose, there were 10 deaths. We had most people not being hospitalized, but I would say there was probably around 130 that were in the hospital.
So roughly about 7 or 8% of the total cases.
Yeah.
Of those who died, was there any profile where did they tend to be of advanced age or heavily suffering from pre-existing conditions?
Yeah, I think, I mean, this has not been made public yet in details, but in general, like elsewhere, these have been elderly people on average, although we did have one younger person that died early on, the first case, and that was in the papers. They had underlying diseases, maybe 1 or 2 like chronic medical conditions in those categories that have in general been the ones that seem to put people at risk, like heart disease, lung disease, obesity, hypertension.
I believe Iceland has been more proactive in testing than many other countries. Did testing testing began even before your first case? Did I understand you correctly, or just as in January when you realized what was possible?
Yeah, it was a month before the first case. It was in late January. The first case wasn't diagnosed until end of February.
Okay. And what are the various testing techniques being utilized?
So there are 2 types, really, I should say. I mean, one is the testing of patients or individuals that have symptoms. Initially, it was focused on those that either had come from what we had defined as high-risk areas, or if they had a known contact with a case. This was later expanded to people with respiratory symptoms. So those are people that seek doctors because of illnesses and they are tested. The second type of testing that has been done here and started in mid-March is so-called screening. And that is testing of really asymptomatic people. So people that are not suspicious of having COVID-19 and they are out, from the public. So it was twofold. There was volunteers who signed up for this when it was advertised, and then there was also random sampling of the population. And this was done by a private company called Decode Genetics, but in collaboration with the Directorate of Health and with the University Hospital.
At this point, what percentage, is it possible to say what percentage of the population has actually been tested?
It's about 12%.
12%?
Yeah.
Which is probably among the highest percentages in any country, I would think.
I think so. I mean, I think Faroe Islands actually have been very aggressive, so they might be a little bit ahead of us. But it is, 12%. We've done over 45,000 tests of a population of 364,000.
And you mentioned earlier that you did undertake contact tracing pretty quickly into the testing process. Can you describe what that consists of?
Right, so there's a special team, what's called the contact tracing team, which is really based from the Directorate of Health and the police with consultation from the healthcare service. They initially were a few people, but they had to hire some extra bodies and volunteers as things got busy for a while. And so anyone that is diagnosed as infected is interviewed, and then all their contacts are so traced from 1 to 2 days before they started having symptoms. And their guideline is about 24 hours before symptoms started. If you all the people that you have been in close contact with from that time on need to go into quarantine. And close contact is defined as within 6 feet for 15 minutes or more, or touching and so forth.
And so all of the afflicted people voluntarily participated in this, and
yes, I haven't heard any problems with that on that end. And then of course people go into home quarantine, and we have to trust them and to do so, and they have instructions of what to do, and they know it's under the law that you're obligated to do this. So I think in general most people have complied. There hasn't seemed to be a big problem with people breaking quarantine.
any other resistance or criticism of other preventative procedures that you've undertaken?
Sure. It's hard to make everyone happy. Even the testing, I mean, in the beginning, even the amount of testing we were doing was more than many places. There was, for a while, a little concern about those testing equipment, the pins, there would be a shortage. It never happened, but there was some discussion. So the doctors, tried to focus the testing on those that they thought needed it. And so there was some complaints about that people wanted them to be more liberal. There were more people that wanted to be tested, and that they weren't. And the same for the population screening by Decode Genetics, that there was a high demand to go there, and there was only so much they could do. And then borders, there were people that wanted to close the country very early on, wanted to close the borders, and also that was directed in the beginning to certain nationalities even, that they would not be allowed to come in as tourists and so on. That didn't happen, like I said, we kept the borders open the whole time. And there have been very few tourists here diagnosed with disease. I mean, very few. Maybe like 8 people or something like that. And then with the social distancing and the restriction on gatherings and those, of course, I mean, there are people that want us to do more, and then there are people that want less. So that kind of goes both ways. And then the last thing I would say is the schools. There has been some resistance to that, but mainly that we didn't go far enough. Where there were voices the whole time that thought that daycares and primary schools should have been closed as well. And it is unusual for an infectious disease like that not to be more affected by children. And children are often the carriers, you know, of infections to the adults. But in this pandemic, it doesn't seem to be. And we only have had 4% of our cases been under the age of 12. We haven't had any severe infections in kids, and only 1 who had to be hospitalized. So for some reason, they seem to be not susceptible to this.
I don't remember if you mentioned that you had any policy regarding the use of masks.
We don't, and we actually did not encourage it, except for people that were ill, so they would protect others if they were coughing or sneezing. And of course, you know, for healthcare workers or anyone responding or taking care of a sick person. Otherwise, we didn't, and we never recommended it for the general public. And that was mainly because, which I think most people agree on, that it doesn't really protect you from getting infected unless you have a special mask and you know how to use it. But of course, it could prevent you from spreading your saliva,
right,
talking, or so on when you go out. So there is some protection, and I think that people do in general agree on that. But how effective it is a little bit unknown, but that has not been a recommendation here.
Mm-hmm. Do you think that the relative lack of residential density, even in Reykjavik, was a plus in terms of the spread of the virus?
Yeah, I think so. I think it's much easier for us to manage this. And I think just the way infections spread, the less dense a population is, the less likely it is that, you know, that many people can get it. The virus cannot live independently and needs a host, and so it goes between people, and in this case with droplets that you either inhale or you touch something, and I think the more people you are around, if you're infected, of course, the more risk is you infect many others. So here, where there's, you know, more open space and less dense population, it's I think it's less likely, and I think it was also easier for us to implement these restrictions and get control than it is in a city with millions of people.
Definitely. Going back to the testing and the sort of interaction with genetic research, you mentioned Decode as a leader in doing a lot of testing. Could you talk a little more about how genetics impacts vulnerability or to the coronavirus?
Yeah, we don't really know, but perhaps there's something like that. We know that men seem not to do as well as women with this disease. And we don't know this because of genetics, but it's possible that somehow the way your body responds to it, maybe the receptors that the virus targets is different. that's possible. But we don't know that yet. We don't know a lot about this disease.
But theoretically, it could be possible that there may be a genetic profile or type which would be more susceptible to contracting the virus than others. Is that possible?
Yeah, I don't think it's out of the question. It's been, like I said, there's been a gender difference. It's also, there's a huge difference in how people respond. Some people, are barely bothered. They get minimal symptoms, or they get symptoms only for a couple of days that are rather mild. And then other people, get severely ill and end up on ventilators. And of course, we've had, the death rate is staggering.
Mm-hmm. Mm-hmm. Do you cooperate closely with the other Nordic countries in terms of coordinating responses or anything like that?
So there is a collaboration. There have been regular meetings between our chief epidemiologist and ones in the Nordic countries, and those have been on a regular basis since this started. I think there's also like a political collaboration to some degree, but there's no like official response or synchronizing of actions that we have done, no.
And no more liberal attitudes towards, say, other Nordics as opposed to travelers from other countries or anything like that?
No, like I said, I mean, the only thing that we have done was to participate in that Schengen area, which we are a part of. Mm-hmm. But otherwise, there's been no difference.
Any cooperation with officials in the U.S.?
No, not that I'm aware of. I think, we're friendly with the U.S. And we follow what's happening in the world everywhere, including the U.S. But the way that our system is made up and our location is such that we look more to Europe and then to the basically the World Health Organization for guidance and direction.
And in your experience, World Health Organization has been a positive force in this, in coordination and response to the virus?
I think they've been positive in a way that they alerted to the situation. They gave some guidance, but they have to think about the whole world, and the countries are so different, and the resources they have and so on. I think perhaps it's been difficult for them to guide everyone. So, and this is a totally new disease, and so many places had to just kind of, I think, come up with their own thing, which somewhat explains why the responses were so different in different countries, and the measures taken also. I think because maybe there isn't a lot of guidance, but maybe it's hard to do.
As you look to the future, do you anticipate a recurrence in the fall? Do you think you'll have to put new policies into effect when the weather changes or anything like that?
Yeah, it's still cold here.
Your weather is always a little different.
Yeah, but that could happen. I mean, what was interesting from the population screening from Decode Genetics is that there was just under 1% of the population had the virus. So it was not widespread in the community. We haven't started antibody testing. We're still validating those tests and hoping to find or have a good one that we were happy to use. But that will give us maybe a better picture of that, how many people have actually had the infection. But if it's true, like it seems, that there's not a big portion of the country has had it, then yes, we are still susceptible, many of us, and we could get infected. And as long as the virus is out there, I mean, it's still here. We have cases every day, although there are few. Certainly it's still around in our neighboring countries and elsewhere in the world. We are at risk. So I think some of these measures that we have now in place will be here at least for the summer and maybe throughout the year, although we will try to relax them gradually, very gradually, as long as things are stable like they are now.
Is there any work going on in Iceland towards discovering or creating a vaccine? Or are you aware of work elsewhere that seems to be particularly promising?
So we are, aware of some work elsewhere. I think, like everybody, there's no work in particular going on here. I think we are going to have to trust others to do that. There have been some news from, most recently, I think from Oxford University, that they are starting some trials. But I know there are several companies that are working on this. So hopefully, that will happen. I think from what we know about making a vaccine, it can take time, and it will take time. And it also will take time to just the production to get it into those quantities that we need to maybe give it, to at least half the population or more, if it's going to have protect the whole society. So that will be some time until we get that. So I don't think we can count on that. I think we need to continue other measures and strategy for prevention for now.
Sad but true, I guess. We have some questions that have been sent in by some of our viewers, and I wonder if I could give you a couple of them.
Sure.
The first is from Linda, who writes, why do some people get so sick, even if they are strong, physically fit individuals with no underlying health problems? And why do others have mild symptoms? Can you give any reason for that?
Well, I don't know, that's the honest answer, but we alluded to it a little bit before. There possibly are some genetic differences that either make certain people vulnerable or protect other individuals. In this disease also, if you have an underlying condition of some sort, it seems to make it much worse. Heart disease, lung disease, diabetes, chronic kidney or liver disease, and then obesity, something we didn't really understand, I think, in the beginning, but has come out now, not only in the US, but also in Italy and France, as possibly being like an independent risk factor. But otherwise, I don't think we know enough to say, and I think those studies will be very interesting to see if we can in the future.
And Linda also asks whether the level of contagion is the same throughout the course of the illness. Is it greater at the onset? Does it decrease as the days go on? And how long after symptoms disappear does contagion exist? Yeah, so we think people that have gotten infected but don't have a clinical infection, they're not symptomatic, that it's very unlikely they can infect others. Although, maybe not impossible, but it seems like people that either have no symptoms or very, very mild symptoms are probably not as infectious or contagious as when you have symptoms. So the more symptoms you have, the more likely it is you will infect others. You have more of the virus in you then. The virus has had time to increase its numbers, and then you're coughing or sneezing, and so that all that will make you more contagious, and that also usually happens as the disease progresses. So you might get the infection, but you might not get symptoms for a few days, and most people don't get symptomatic until maybe day 5 or 6. And then as the disease goes even further, I don't think we really know what happens then, if it stays the same or even if it gets less. When you have had it for a long time, it's a little bit difficult to tell. And Janet asks whether you see a great deal of recurrence in the cases you've seen in Iceland. Have you seen second and third time illnesses? None that we have confirmed as being such. The doctors here think it's more that people, they feel better, they think they're better, they even say I'm fine, and then a few days later they have symptoms again.
And they think it's just the same infection. It's not the new infection that you got from somebody else or so on. It's just you still have the virus. We know people have the virus even if they have, clinically recovered, at least for 1 or 2 weeks, if not longer, maybe 4 or 5 weeks. It's just hard to say what that means. You have the virus and it will come, if you're tested, it's in your, in the nose, in the throat from the test. But the way the test is, this is not a blood test, this is a swab that tests for the genetic material of the virus. And you only need to have a little bit for the test to find it, if it's done correctly. And sometimes you don't know if that's viable even, and you don't now know the amount. So it doesn't mean necessarily you could infect others. So this is still something that's a bit uncertain. I think those antibody tests might answer some of those questions.
Very good. I think there's one other question here that was from Eva. What are Iceland's experiences with false negatives and false positives in COVID-19 testing?
Yeah, I mean, all tests can have both of those. I think we are seeing more of false negatives, so to speak. People that are maybe asymptomatic, have a test and it's negative, meaning saying that they don't have the virus. And then a few days later, they have symptoms, they test it again and they have it. So they probably had it the whole time, but because they had, symptoms or just the virus hadn't replicated to that extent that it was able to be detected, they are false negative. So even if it's a very good test, I think that's what we've seen more. I think if the test is positive, meaning it says you have the disease, I think then it's very good.
Mm-hmm.
That's not really a concern that it's a false positive, that the test says you have it, but you don't.
Okay. Our time is running short. One more question, which came from Michael. Do you see any positives emerging out of this pandemic, such as unexpected advances or discoveries or societal changes?
I mean, that has been a little bit hard, I think, these days to think about this as positive, but I think everything, of course, maybe has something positive, and this will too. I think our focus on hygiene and maybe some of the social distancing, at least for some countries that are not used to that, can be overall positive in a way that it will just in general decrease infections, even for the common, yearly influenza, which, infects thousands of people every year. Some of the distance learning in schools and working from home for people could offer more flexibility that might be an advantage if we use it right. Also might decrease travel and pollution, which we have seen really amazingly in these days, that when people are not out driving. And
yes, we have very clear skies.
yeah. What else? I mean, for the hospitals, I'm sure they've learned the hard way how to deal with crisis, even if they're smaller ones than these. I mean, those are big lessons that they can take away. And same for the pharmaceutical industry. I mean, there are companies now developing, like we talked about the vaccine, they're trying drugs, a lot of innovation and development going on that will not only help, I think, with this virus, but others or other diseases. Yeah, those are a few things, I think.
Well, there's some hope, right? Well, Gudrun, I appreciate this very much. Our time is running out, and I'd like to thank you for the most interesting presentation. And I really appreciate you giving the time. I know you're terribly busy, and It's great that you've been able to do this. I'd also like to thank the ASF staff who have handled the preparation and technical production of this webinar, specifically Lori Fredrickson, Sally Yurkovich, and Kyle Reinhardt. And I'd like to thank all the funders of the American-Scandinavian Foundation, and especially the Barbara Osher Pro Suecia Foundation and the Icelandic Cultural Fund for their support of ASF programs. Again, Gudrun, thank you so much, and thanks to all of our invisible participants. Some questions might have come in. I couldn't see them all, so I apologize if I wasn't able to get them on my screen. I'm only seeing fragments, but nonetheless, I hope we'll be able to do this again, and thank you for being with us. Gudrun, thank you. Goodbye.
My pleasure. Thank you. Bye-bye.